Hello, everyone. Welcome to the PMP Pals Hope Zoom. How is everybody today?
Good, thank you.
Good. There's
Good.
James.
Got the fleece on, it's cold here.
Yeah.
In Texas, it's quite warm still.
Well, I'm in Ireland, so it's quite cool here.
There you go.
In San Diego, we're enjoying a little cool morning. It's been warm here still, that Indian summer for us. It's a nice cool morning today.
We have an
So we
orange
have-
sun this morning. Still fires up here a little bit still.
Florida's always hot.
Welcome everyone to the PMP Pals Hope Zoom call. Nice to see everybody today. We'll get started in just a moment. Dr. Wiatrek, I didn't mention, so I've worked for Varian Medical Systems for 10 years, radiation oncology. So Texas Oncology Associates was a big customer of ours for sure.
We treat a lot of cancer patients. I mean, US Oncology, who's our blanket, who's our big partner. I mean, it's the biggest oncology group in the nation, obviously.
Yeah.
We have places everywhere, but Texas Oncology is one of their bigger practices.
Wow.
Yeah, and Dr. Wiatrek, I'd like to introduce you to Charmaine, one of our colleagues. Charmaine lives in Austin.
Great.
So after COVID, you'll have to connect in person.
Yes, I've been wanting to get together with you. I'm a patient of Dr. Chada's. I've been a patient of Dr. Chada for 11 years.
Oh, wow. Okay.
Yeah, he does my surveillance, and I had my surgery with Dr. Sugarbaker 11 years ago, and I've been seeing Dr. Chada ever since then.
I will find it interesting to see what sort of surveillance he's chosen because, you know, as you know, everybody does something different.
Yeah. It's nice to meet you.
Very nice to meet you.
Well, why don't we go ahead and get started, and give me just a second to share my screen. And welcome everybody to another episode of PMP Pals Hope Zoom. We've been supporting patients since 1998, as Gabriella Graham showed us to do, and super excited to be here again. It's always the highlight of my week being here, and the other pals and the board of directors. Most of us are here because Gabriella got us to care. So we're excited to continue doing that with you. Just a few things to keep in mind as we start to talk today. So while PMP Pals, we have experienced patients and caregivers, we're not licensed to give medical advice. We are very excited to have Dr. Rebecca Wiatrek with us today, who will be talking about surveillance of PMP and appendix cancer. And so she is a licensed professional, and we're excited to have her here. But just keep in mind that PALS in general, we're not medical professionals, not qualified to provide advice, and you must seek care from a licensed physician. With physician presentations, you may see graphic images or data that's scary. We did review it with Dr. Wiatrek today, so we don't anticipate seeing that, but keep that in mind. And while we try to keep your health, your identity and health condition anonymous, we can't guarantee that. It can be tricky to work with Zoom sometimes, and so your likeness may be shared with the public. We do share these presentations, especially the physician ones, because they are so popular. So your image will be shared if you share your screen, but you're welcome to change your name, and you're welcome to hide your image as well. You don't have to share your screen. And then just a few ground rules. You know, this is a physician presentation, so it's a little different, but we want you to know we're here to support you and provide you with information. Stay here as long as you'd like. Do not feel obligated to stay here. If you're tired and need to go, that's okay. If you have other obligations and you're enjoying life today, we celebrate that. So be here as much or as little as you'd like. You can use the chat features to talk to one another. If you have questions during the presentation, you can email zoom@pmppals.net, and I am monitoring that channel, so we will get through all the questions today. And that's it, right? We're always online at pmppals.net on Facebook and Instagram, and we're glad to have you here today. And with that, I'll say good morning to Dr. Wiatrek. How are you today? Thanks for being here.
I am great, and I am going to share my screen. I'm very happy to be here. I will tell you my last name is difficult, and you're saying it correctly, except I pronounce the W like a V, and it makes it almost as hard to say as pseudomyxoma. I say it Wiatrek, which just makes it difficult and confuses patients when they call into my office and my office staff says it the right way and they read it a different way. So I'm very, very happy to be here to talk about surveillance. When I was asked to do this, I looked at all the presentations, and this is one that nobody tackled, and I can tell you the reason nobody tackled it is because we are still answering the why, when, and how. And so I will get into that a little bit as I go through the presentation, and I think I'm going to answer some of the questions that you guys have already sent in, which is great, as I go along. And then if you have more questions, I'm happy to answer those. So let's just start with the why. Okay, so why do we monitor after cytoreduction in HIPEC? And I kind of get this answer, this question sometimes. They'll say, why are we doing this? I thought you got it all. I thought everything was great. Well, you know, there is always a risk of recurrence based on pathology. And so when we talk about this when I talk about this with my patients, I say there's such a variation in pathology. And I almost feel like this is a fruit basket turnover. So if you look to the screen over here, you'll see I've tried to highlight all of these letters that we like to abbreviate everything with. There's a lamin, a low-grade appendiceal adenocarcinoma, high-grade, low-grade, here, this, that. And what's not even in that little documentation is GCC, which is goblet cell carcinoma, and I put in CRC, which is also colorectal. So we do cytoreductive surgeries, and I know you guys have already had a pathology presentation, but we do these for a lot of different tumors based on how they function. And so it is a little bit comparing apples to oranges and pears, and so it's one of the reasons why we don't have consensus on some of this. So the reason we want to do the surveillance for you guys is we want to find recurrences before you have symptoms. We really want to know when the disease comes back, if it does. It doesn't always, but if it does come back, we want to know what the volume of disease is and if that volume is affecting you. This will help us sort of determine when is the right time to have a shorter repeat cytoreductive surgery in HIPEC. I can tell you I have a third one on a patient coming up soon, and I have done as many as 3, and then some additional cytoreduction. So you will see repeat cytoreductive surgeries on patients. However, each time we reopen the abdomen, that adds in some risk. So we do like to follow along and know what we're dealing with on the inside. So repeat cytoreductive surgery, HIPEC, and timing. So this is one of the more specific features as to why we want to do the surveillance. And I don't surf, but I put that surfing picture up because I have tried, and timing is everything. If you pop up the wrong time, it hurts. And that made me stop doing it. And so timing may be everything with this. You want that shorter repeat HIPEC. That reopening of the abdomen does add risk. And some of you guys have probably been there, and you know that risk can be scar. It can be having a problem with any part of the surgery that's been done, including putting intestine back together. And we sort of believe that the longer time we can get in between those surgeries may equal longer overall survival time. And you know, the data for this, and this goes back to my fruit basket turnover reference, the data is very difficult for us to interpret because there are and continue to be a large range in a very rare tumor, but they all sort of behave differently. So comparing it is like comparing apples to oranges. Okay, so that's a little bit on the why. And let's talk about the when. When do we start doing this? So when will you have your first scan? One of the themes here is it varies. And I think that for me, after a patient has a cytoreductive surgery in HIPEC, I will get their first scan after they've recovered to get a new baseline, okay? And I base it on the tumor biology. I'm referencing here this fruit basket turnover again because not all biologies of those tumors behave the same. So if the patient has had a scan in the hospital for whatever reason, I can sometimes use that as my baseline, but I typically will give one at 3 months. I will say there is no consensus. So you're going to see probably the most variation you'll ever see in surveillance for you guys. So I know in your support group, you might notice that there's a lot of different ways that people are watching or being watched for tumor recurrence. And so I put that little sign, my way or your way. And of course, we all think our way is the right way. So when will you have your next surveillance scan? Again, this varies. And I mentioned in my slide, this is a theme again, because there is no consensus. And it's based on tumor biology. And we sort of base it on our presumed risk of recurrence. And I put off to the right of the screen a little diagram about how we see tumors progress and different pieces that the tumor will find to sort of bypass the normal biology of a cell, start to grow and behave more aggressively. But if you can look at that, there's tons of different ways that the tumor can change. And so there's many different ways that these tumors can behave. So what will be my schedule of follow-up? So, when I have a patient have their surgery, they initially have quite frequent visits with me. And some of this is to get them back to their baseline, to control any issues with eating and regaining normal bowel function. And we can make little adjustments to have a better quality of life post-operatively. But it does take a little while, as many of you know, to get back to that baseline. And then this range seems ridiculous to me as I wrote it down, but if you read the data that's out there, the range is somewhere between 3 to 12 months. And that range again goes back to our tumor biology. And we sort of make these decisions based on what piece of fruit you have. So most of us will do a 3-month to start with. Unless you have something that we believe based on your pathology from the surgery may behave a little more slowly, and then we may extend that out a little farther to start with. Most of us want to make sure we don't miss something, and for that first portion, we'll get a 3 to 6 month scan and start at those intervals. And so that's sort of how I made my decisions. I will tell you this graphic, it was hard because unfortunately when I looked at decision-making graphics, they mostly had men there, so I had to find one that had a female making those decisions. And so there is a lot that goes into these decisions, and some of that is how you are behaving after the surgery, meaning how your GI tract's behaving and if you've developed any symptoms or if those are getting better. And again, I had to write this down, there really is no consensus. And so we as oncologists are used to standard of care, and so the consensus we have for colorectal cancer is very standardized, and you will get that at any clinic you go to. They will usually have that same recommendation. But you will find with pseudomyxoma and our appendiceal variants, it is vastly different. Okay, so on to the how. And I'm going to try to talk slower because I think I'm talking pretty fast for you guys here. So how will you be followed? CT scan, MRI, diagnostic laparoscopy, tumor markers, clinical exam. And I'll go into each of these sort of separately. So first, the CT scans. And I get this question a lot. Well, what are we going to scan? Which parts of my body are we looking at? So-and-so gets their lung scan too. Are we worried about my lungs? Should I get a chest CT scan? And again, this really goes back to the tumor biology. Our surface spreaders, depending on where they come from, may have just the potential to spread in the surface. And very rarely do we see the low-grade appendiceal mucinous neoplasm sort of going from the belly into the chest. Chest spread is more hematogenous, meaning it goes through the blood, and it's acquired some of these characteristics off to the side where it can get into blood vessels and go. And so some of the tumors that behave more like a colorectal tumor or the goblet cells, those are more likely or more able to have the potential to spread other places. And so your scans may involve something more than the abdominal cavity where we did the surgery. So pros and cons of CT scans, and I put up a couple pictures here, and I think a lot of people will see these when they come into their clinic visit, or at least I tend to show the scans to the patient so they have something visual to see. The pros of a CT scan, it's pretty easy to do. You don't, if you're claustrophobic, it doesn't matter. The donuts are typically open. You get contrast with it, but that contrast dye, unless you develop an allergy, tends to be well tolerated and doesn't have any long-term side effects. Cons, you do get some radiation with each scan, but at the end of the day, I think it's important information, and that risk with the radiation is low when you compare it to the risk of missing a recurrence. And the other con with CT scans, and I'll show you here, along these edges, you'll see they're a little fuzzy. So this is the pancreas, and here's a little picture of the small intestine and along the liver. And so unfortunately, this disease can sometimes look exactly like these normal edges on a CT scan. And so we look for disease up here by the liver and other places. But what I will tell you is that a CT scan is not perfect in trying to find this disease until you get enough cells to make something thick enough to see on CT scan, which is usually at about 1 centimeter thick. We really struggle to see if there is a recurrence. And so you will see bigger things on CT scan, but small volume disease or just layering of all of these surfaces, which we know these surface spreaders like to do, is pretty difficult to see on a CT scan. I will tell you, I tend to look at the CT scan before the patient goes to the OR. I do my surgery, I follow it after, and I document in my notes and in my operative report the areas I'm most concerned about recurrence, so I can personally look at them myself and sort of figure out if that's the area that looks different to me, and it sort of helps me decide if I think that's scar or if it's tumor, and watch it pretty closely. So I would say most people in the US probably get CT scans. However, there are some people that like MRI scans, and this is a little example of an MRI scan, and I'll pop back up to the CT scan. The CT scans look pretty clear. MRI scanners can be a little clearer. So there's some argument with some people that they prefer MRI scans for patients and they can see these surfaces a little bit better. The cons of it are, if any of you have had an MRI, you do have to lay really still to get these good pictures. And so sometimes to be able to lay that still for as long as it takes, which can be over 30 minutes or more, is hard to do and sometimes need sedation. Additionally, to get this distinction between all of these areas in the abdomen and the surfaces, you need contrast dye. And the contrast dye has been studied over the last couple of years, and they have found that it accumulates in the brainstem. So patients who get multiple MRIs with multiple contrast they've noticed that for some reason they see residual dye long-term in that area of the brainstem. Now, we haven't really had definitive documentation that it causes anything clinical, meaning we are not certain what it does to have it there, but most of us are a little nervous about it having that behavior in the brainstem because we don't know what it will do, and we don't want to make something worse for our patients. So it is being watched. So we'll tell you, we have sort of gone away from MRIs if there is another modality that works just as well. The other thing that you need in this con is not every place has the magnet level, needs a 3 Tesla magnet to get a good picture. And so not all MRI scanners are made the same way. There may be a few in the nation that are great, but I'm not sure it's worthwhile to travel across the nation to get a scan when you can get one that might look exactly the same in a different modality. So I will leave it as some get MRIs, and that may be good for your situation. Okay, diagnostic laparoscopy. So, there's been a lot of talk about doing this for patients. I will tell you, the pros of it is you can see the surfaces. Now, it's great, and I put at the bottom of that on the list, meaning before you've had a big open surgery. I think these are great. You can look in with a camera. I use a 3D camera. I look around on surfaces. I can biopsy. And so it helps decision-making in terms of is this patient the patient that needs their first HIPEC? Because as we know, not all tumor volume or pathologies actually need a HIPEC. There are some that you can watch and wait depending on what the disease is. And I can give you an example, and I did have permission from my patient to give this example. So she was diagnosed with pseudomyxoma at an infertility workup, and it was within her tubes. And so when they went to wash out her tubes to try to figure out why she could not get pregnant, they found acellular mucin in her tubes. So we performed an appendectomy and did see a ruptured low-grade mucinous neoplasm. I have now performed, I think, 3 diagnostic laparoscopies on her with biopsies, and the first one had some acellular mucin, and I took everything out that I could see. And since that point, the very last one had only scar, and I was not able to see any mucin. So she has never had a HIPEC. She's now had 2 children, and is planning on possibly having her 3rd one. But we are continuing to monitor her, and I think for her, in her young age, the diagnostic laparoscopies have been at lower risk and have been a pro for her to be able to know that we're not going to get something out of control while she's pregnant. And so I think that is a great tool to use for that sort of surveillance, and this is a pre-HIPEC surveillance. Now, the cons is, once I do the surgery on you guys, and I'm sure you know this, that second surgery, as I mentioned earlier, has a little higher risk because you have a lot of scar in your abdomen. And I think that it's a huge variation in who makes scar and how much scar, and it sort of depends on what I do. I have found that the chemotherapy makes slightly different adhesions in patients that have surgery that I don't do that portion in, and I take care of other cancers as well. So I don't have, that's anecdotal, so I have absolutely no data. It's just my experience. And it's been variable. There are some that the scar is so robust, you can't make heads or tails of anything. And then others that, although it takes a couple hours to get to where you can identify anatomy, is worthwhile, and you do sort of, you are able to separate organs. So with a diagnostic laparoscopy where things have to separate and can't be scarred together, it's not really how you can monitor a patient, because you can't see very well. So if you were able to get in, most of it would be scarred. So the areas you want to look at, you probably couldn't get to. So I think it's an exercise in futility to do it in a patient who's already had the procedure. Okay, I don't know how to make this go down. Okay, so for tumor markers, this is another way that we follow patients. We do like to get the tumor markers, delete this, on the patient up front. This is while you still have the tumor intact. So what that means is your tumor sometimes gives off these antigens that we can see in blood. Not everybody makes them. Not every tumor makes them. And it goes back to the fruit basket turnover, because all of them sort of behave differently. And so with these markers, it sort of gives us something very sensitive to follow. I have found that with higher burden of disease, meaning the more disease we find in your belly, which is a higher carcinoma index or PCI score, which I know some of you are familiar with that terminology. So the higher that score goes up, the more likely some of these are to go up. And so these are pretty sensitive if your tumor makes them to follow. So all 3 should be checked. And you can debate how often you check these if they were never elevated to begin with. So I have patients that don't have a CEA, a CA19-9, or a CA125 that's elevated. And if those aren't elevated, I will still check these at intervals, because I believe if it does become elevated, then we need to start looking for where that disease may be, maybe returning. But I will say they can be elevated for other reasons, and sometimes you end up looking for things that aren't there. So how often do we do these? Post-operatively, I will get a new baseline somewhere between 3 to 6 months, based on, again, whether you're the apple, the orange, or what sort of tumor biology or pathology you have. And then we do that at intervals, again, based on that pathology and whether or not they're elevated. Okay. Wrong way, sorry. Clinical evaluation. This I do on a routine basis for my patients, whether I'm getting a scan or not. And the theme again is 3 to 12 months. And that range is again based on the biology. So I put my little fruit basket there again for you guys. But you know, this is really to evaluate for symptoms and to make sure the quality of life is good, bowel function is good, and you're sort of getting back to something that you consider normal. I do like to do the abdominal exams. I find that with these long incisions, there are certain things you can do with physical therapy and stretching that can help those incisions not feel so tight. And additionally, you know, just making sure that you're not developing symptoms that, number one, could be treated medically, or that make us change this every 3 to 12 month surveillance. If we're watching a symptom pretty closely, then that may change how often we recommend those above sort of evaluations. So I think I went through this faster than I thought I was going to go to, and sometimes I just talk too fast. But I will say in my conclusions, I don't think a consensus exists. And so our consensus is there's no consensus. And at our meetings, you know, everybody has a little different way to follow patients. And it is really tailored to your specific pathology, tailored to the surgery you had, tailored to your history. And if you've had a recurrence before, if you hadn't, and I put in big capital letters, we need more studies on how to surveil this. And I think the challenges with that is, you know, this is a fruit basket, for lack of a better term, of pathologies. And we try to do studies with an already rare tumor that within that rare group has many different behavior of pathologies and try to figure out what the right thing is to do for that whole group. And I think, you know, at the end of the day, the answer may be it needs to be tailored to the patient, because we won't be able to get a consensus on what's right for each patient. And it needs to be what's right for you. And that's a discussion with you and your physician about what's right to monitor you. Okay, so I am going to the question. Do we want to stop and pause here for a second, or do you want me to go straight into these questions?
Yeah, I think we can go. So everyone, some of you submitted questions in advance, and so Dr. Wiatrek has those, and we'll go through those. And then when we're done with that, we can, if you have additional questions, you can raise your hand, and we'll try and call on you to get those answered. But just a quick one before you start. Would it be safe to say, though, patients need some sort of surveillance plan?
Absolutely. And I think that you should be able to ask your physician, what's my plan? When am I coming back? What do I watch for? What are we going to follow me with? And that answer may be different based on your specific disease, but there should be a plan. So that there is a consensus on. Everybody should have a plan for follow-up. So what I have seen, unfortunately, is we think you're great. Go on. And then I see them 8 years later and they have a pretty extensive HIPEC for that. So in no way should you fall off of surveillance. There is some data that shows maybe at 5 years, if you have one of the low grades, you may be free to not follow it. But I don't think there was a lot of patients in that. And so it makes me nervous. I still continue to follow those patients just at longer intervals. So absolutely. Okay, the first question I have here is reoccurring appendix cancer with early stage breast cancer once, a PALB2 and ATM genes, appendix cancer tumor removed last month, currently being tested for additional mutations. How do you keep watching things enough while trying not to overdo testing? Well, I will tell you, after reading this question, it seems pretty complicated. You know, I can't tell if these genes, it may be different based on if the gene mutations were within the tumor or were they germline, meaning do all of your cells have a mutation that makes you at risk for this cancer and maybe other cancers? Because if that's the case, if it was a germline, you may need more, you know, you can do too, there's always too much, but if we know those genes, we may be able to tailor your surveillance to the ones that are more likely to occur for you. I think when we talk about overdoing the testing, you have to look at the risks. And, you know, we talked about some of the risks with radiation and some of the risks with the MRI contrast dye, but not all of those, they are additive over time. So I think if you are being followed by multiple people for different cancers, I think you need to make sure that if you're getting one staging or one surveillance, that you try to combine what you can combine, and that may limit that or stop sort of the overdoing. But I think for me to be able to decide how to follow your appendix cancer specifically, and I do treat breast cancer as well, so I could tell you what my recommendations would be, but I would really need to look at your pathology, because as I mentioned, it's which piece of fruit are you? And do you have something that makes each of your genes sort of at risk and each of your cells at risk? And that will change my clinical suspicion and how often I want to watch you. Hopefully that answers it. Yes? Okay. Okay. The next one is GCC recovery. And so goblet cell carcinoma is different in behavior because it has a different biology, but it also within itself, there's high grade, low grade signet ring, and each of those behave differently. I think from a recovery standpoint, if you had a cytoreductive surgery in HIPEC, that's going to depend on what organs were removed, how long your surgery was, what has to heal on the inside, and sort of how you came into that procedure. So a lot of goblet cell carcinoma patients will end up with chemotherapy first. And so sometimes you're a little bit behind the curve as you start your recovery period and your surgical period. And so there's a lot that goes into that, but I think you could compare apples to oranges in this instance, because that surgical procedure, if you find somebody that has a similar surgical procedure, similar organ resections, similar sort of time in the OR, you may have similar recovery periods. So I think that could be the same, depending on all of those factors. So hopefully that answers that question. We'll have time at the end if you have something more specific to these questions and you have a secondary question after I answer it, I'm happy to answer that as well. The next is cytoreduction of HIPEC doable when the cancer has spread to the small bowel. So that's a complicated question. If it is spread to the small bowel and it's in limited places, then yes, it is. And I have resected small bowel for cancers, and I have removed many little tumors that were on the surface. Now, if the surface tumors start to grow into the surface more, and it's along the blood supply, and it is a lot, then you really can't achieve much help. You can't scrape all of the intestine off. And I like to tell my patients, there's a lot of organs in your abdomen that you can live without. You can't really live without your small bowel. It is what gives you your nutrition. And so you can take out quite a bit of it, but you are limited. Just like the liver, you can take out quite a bit of it, but you still need your liver. And so that becomes a challenge, and it depends how much disease and what type of disease. So I have scraped the more mucinous components off of the small intestine and washed that with chemotherapy, and I have seen good results with no recurrences in that area. But it is, again, a little bit variable. So that depends on the details of what that spread is like. And I will say, when we look at our CT scans and our other stuff, it doesn't always show that small bowel disease very well. And this is one of the things that happens when I think it's possible to do a cytoreductive surgery, and then I get in there and I'm like, we can't do it. And it's usually extensive small bowel disease that limits what we can do. Or the other thing that limits it is really extensive disease around the blood supply to the small bowel or the liver. Those two areas you need. You don't need your colon. There's a lot of things you don't need in the abdomen. People can live without their stomach. There are a few structures that you just absolutely have to have. Okay, see, the next one. I have metastatic well to moderately differentiated mucinous appendiceal adenocarcinoma, status post cytoreductive surgery HIPEC with multiple lines of systemic chemo, now undergoing FOLFIRI, 1 year reoccurrence after HIPEC in 2017. Welcome to share my story. Okay, what's interesting on this one is you've had one cytoreduction, so I guess I have a couple of questions. on this that would change sort of my answer on what we would do. What I tend to do is if a person has a recurrence after cytoreductive surgery and they've also had chemotherapy, and these are for our adenocarcinoma patients, because as you know, the low-grade patients don't typically respond to chemotherapy and we don't typically give it. And for the patients who have adenocarcinoma, which is really the invasive component, meaning its biology has acquired some of those other things along the wheel where I showed you that tumor biology graph or diagram, it depends on how you recurred. So if you had a HIPEC and it was peritoneal disease and you recurred in the peritoneum, you may be a candidate for a repeat HIPEC. If you had peritoneal recurrence to begin with, but now you have recurrence in your liver or lung or other places, then surgery doesn't typically help those areas. So it has to be in an area where surgery can help. And maybe small volume. Sometimes with small volume, you can also achieve some control using other modalities like radiation in the lung. Liver, you can resect, but it depends on how much disease. And most of the data we use for liver resections come from colorectal cancer. And so we sort of look at if the appendiceal cancer has the tumor changes that the colorectal cancer does, and if it's behaving in that manner. Now, looking at this with FOLFIRI, all patients with, not all, I would say the vast majority of patients who have peritoneal disease and surface spread respond to Avastin. And if you haven't had Avastin, that is typically something I recommend. That is newer data that has recently come out that shows a better improvement in treatment with Avastin. Now, not all patients are candidates for Avastin. If you have fistulas, if you're at risk for healing, and there are other things that go into it. So there's a lot that goes into those decisions. And I think, again, this sort of appendiceal cancers end up being some of our most tailored treatments because we just can't get a consensus because there's such a vast array of how they behave. But if you have more details or you have specific questions secondary to that, I'm also happy to try to answer this for you. Okay, next.
Dr. Wiatrek, so Mary, would you like to comment? Okay, you're on mute. You're on mute. So you need to unmute your.
Push your unmute button, Mary.
Here.
Sometimes that's the hardest button to find.
It is.
There she
It should be the easiest button
There
to
we
find.
go. Okay, Mary, you've got some follow-up questions?
Yes, I do. You know what? I was on Avastin.
Uh-huh.
Actually, it did stop the growth, and in one area, actually, it did shrink. However, I was getting severe facial pain. Like, you know, feels like someone just bops you in the nose. And it would go away. And then they almost thought I was getting, is it trigeminal? Neuralgia. Yeah. And so they took me off of that. And I'm just wondering, from your perspective, is the benefit of the Avastin greater than putting up with the pain? In other words, should I have just stayed on it and just lived with this facial pain? Or they have the Avastin right now and just have me on the FOLFIRI?
You know, it's hard to say. I mean, I don't give these chemos, but I know Avastin is not always the easiest to give. And, you know, some patients don't tolerate it at all. And there are others that I've seen on it for years. But I think at the end of the day, you have to decide what your quality of life is like with that. I mean, trigeminal neuralgia is not an easy thing to deal with. And if it goes away off the Avastin and it's not one of the other chemotherapy agents, then shoot, I don't know if I would want to deal with that often. And
once I went off, it stopped.
So I would have, you know, you'd have to assume that it's from the Avastin. It has a long list of side effects. And although we get good responses with it, they're not so, we like to try it because sometimes you'll get amazing responses, but I don't know if it's worth the trade-off if that's your symptoms from it, because it can be additive and you don't want it to continue to get worse. Okay. I think the other thing too is, I don't know, you know, there's always consideration for a second HIPEC unless you have other areas of disease. And so I think that has to be in consideration too.
Right now, I think I have too high a burden of a disease, and it's a little bit
Sorry?
close. I have too high burden of a disease, my reoccurrence, and then I think by the location where it is on the liver, they don't want to go back in yet.
Okay. Yeah, sometimes, you know, if you get liver parenchymal, so I always tell patients there's a difference between parenchymal disease and surface disease. So I can wedge pieces of the liver and do a HIPEC, and you can usually get away with it. You increase your risk to do a formal liver resection, meaning taking a bigger piece of the liver off. And sometimes that trade-off is you don't have enough residual to sort of withstand some of the chemotherapies. So if it is truly inside the organ and not on the surface, the ones on the surface I don't feel have that much impact on your liver, and your liver function, I should say. The ones on the inside, to get those out is a little more challenging. And those are the ones that you want to see a response to. I will tell you, surface, anytime it's invasive, I like getting chemotherapy, but you don't always see a robust response if it's a surface liver lesion. It may just sort of look the same, and at some point you decide whether or not you're a surgical candidate or not. And that is a discussion with, you know, the surgeon who knows your abdomen and knows what's possible. And I think that's sometimes hard to figure out.
Yeah. Okay. Thank you very much.
I hope that helps.
I should.
I'm sorry, go ahead.
I was going to real quick. So does the full Fury, which I'm on right now, do we think, should I be hopeful that I'll at least see some result to that since I'm not on the Avastin? Have you seen?
I mean, we see some responses. I think, again, when I'm giving patients chemotherapy and they have a mucinous tumor, I don't get upset, and I don't say they can't have a surgery when their peritoneal disease gets thicker or stays the same, because it doesn't always have an impact on the peritoneal disease. What I like to see is when the patient has ascites and the chemo makes the ascites go away, I find that a positive response to chemotherapy when I'm making my surgical decisions. And if they have any sort of lymph node-based disease or other disease, I would expect that to change, or lung disease to change with chemo. Sometimes you can't get, you know, if it is not a very robust tumor in terms of having vascular supply, then it's hard to get the chemotherapy to those areas in a quantity you need. So although that's a little complicated of an answer, I think that you can still see some response, and it sort of depends on what you're looking for the response in. And so I'd have to look at your scans and tell you if I expect that to change or not. And I can tell you, I've taken some of those patients to the OR where we didn't get as robust a response, and sometimes I am able to cytoreduce them, and sometimes I'm not, because it is worse than I think. And it's a little bit hard to predict. It's a little easier for me if it's a second time around and I know the patient. I can look at that disease, but it's not perfect.
Okay, thank you.
You're welcome. Oh, I'm on next.
Next question.
Let me do the next question. Okay. Okay, here we go. 2 weeks post cytoreductive surgery, HIPEC. I was admitted to the hospital with acute bowel blockage and recovered after 12 days. Adhesions were the cause. Will those adhesions be smaller now? I am 2 years post-op and bowel blockage. Well, you know, it's interesting because everybody's scar is different and what they make. And you can have scars contract over time and get worse, but they can soften up. And I think it's pretty hard to predict. What I will say is an immediate post-operative sort of bowel blockage that was really close to your surgery may have more to do with your intestines being swollen and other things in there swelling and not being able to sort of overcome the scars that were forming. If it has been 2 years, the farther you get from that blockage, the less likely you are to have another one, although it's not perfect. But I think that's a pretty good sign that it's been 2 years. So the adhesions may be smaller now. I think, you know, what I tell patients is don't ignore symptoms because you could still get another one. But a 2-year period with not having them is pretty good. And I suspect the, you know, closer to surgery blockage was likely your bowels hadn't really sort of recovered completely. Let's see. Next one. I am asking about the long-term effect of HIPEC on the peritoneal and organ surfaces and its effects on and cause of future adhesions and blockages and hernias. Does HIPEC increase the risk of some depending on the diagnosis type, grade of appendiceal cancer? When we look at what the chemo does to the surfaces, you do have an initial sort of penetration of that chemo, and patients may get more systemic effects if we have more raw surfaces, meaning there's more blood vessels where that can be absorbed. And so extensive liver capsulectomies, it may go into the system. In terms of it staying on the surface, I don't think we have great data that tells us one way or the other. It's an assumption that it probably does not stay there forever, and we don't expect it to. We tend to wash it out at the end of the case and hope that it's lysing those cells immediately and not waiting and keeping it around. Now, if you had something like EPIC or a dwelling catheter where the chemo is sitting around, that may be different. But for HIPEC, I don't necessarily think it's sitting there functioning longer. Now, in terms of adhesions, I think there is something that makes it not as, it does do something to the tissue around it, where I've seen patients not really have as much scar, and then I've seen patients have very robust scar. And some of that I think is just the interplay with the chemo and what the patient's natural proclivity is to scar. And some patients scar a lot and some don't. And I will tell you, we studied that for a long time, and we really have not come up with a reason for that, and why one patient will do that and others will not. In terms of bowel blockage and hernias, that more has to do with what sort of surgery is done for you and how much is removed. And if you have a lot of small bowel work and a lot of anastomosis, and how you really scar on your belly. Because if every surface is touched, I think you can scar in all sorts of ways. And I will tell you, I move stuff around before I close up and try to hope that it scars in the way I want it to. And it doesn't always do that, but I do spend some extra time because I feel like if it does help at all, I'm going to try it. I don't think there's anything to support it. It's just what I like to do in the OR. It also helps with my obsessive compulsive symptoms. And so I like to do that because it's a lot, it makes me feel better that I've done everything I can. But in terms of hernias, I think the chemo probably does increase your risk a little bit. With that chemo installation, you do have delayed healing. There can be periods of lower white cells, and white cells are needed. So that immunosuppression, those cells are needed to heal. And so you may not form so for the same reason, maybe you won't form as many scars as other people who don't get the chemo. It may form a hernia because you don't heal that area that we want to heal and scar up and be strong as well either. And so there is a risk for hernia that's slightly higher than other surgeries. And some of that depends on what's been done in the OR. Now, is the risk different based on the diagnosis and type or grade of appendiceal cancer? Probably not. But as the low grade tumors, I think, I have to go into every crevice in the abdomen. And so those cases are actually longer than some of my invasive ones that stick and may not be in every area. But I think it's more dependent on your PCI or how much disease you actually have. So some of the high grade ones may have more disease, but in my experience, the low grades tend to be all over the place, and we scrape them off of things. And I think that's more risk of getting adhesions and blockage just because you've touched every single surface in the abdomen, whereas some of the other ones may not. So I think that's a mixed bag as well. I feel like I'm saying that a lot for this presentation. Let's see, the next thing, if doctors know you have a cancer inside you, why don't they take action? Why let it grow and become worse before treating it? I talked a little bit about this in my presentation because the timing of surgery is important. Sometimes we want to know if it's responding to chemotherapy. Sometimes we know you're going to have a second surgery, but it's slow growing. And do we wait until you have symptoms? We don't necessarily like that. But if we don't want to wait and change a 6-hour surgery to a 12-hour surgery, but that longer period, if you're functioning for these slower growers, may actually allow you to have more time off of therapy and more periods of normal life, meaning your quality of life during that time is great. And then you have your surgery and you're recovering instead of you having a surgery every year and then recovering and only have 6 months of sort of free from your disease, to say. And so I think that there's so much that goes into that. Now, when you say take action, some action has to be taken, whether it's surveillance and watching it closely to see if it's growing and monitoring your symptoms. And if it's high grade or signet ring or GCC or colorectal, you know, some sort of treatment probably should be happening, whether that's chemotherapy or a plan for surgical intervention. But for the low grade tumors, sometimes it does seem a little crazy, but we do watch them a little bit longer because they do grow slower, and we're trying to pick the right time to fit in the marathon and not the race.
Dr. Drew, I'd like to interrupt at this point if I could.
Sure.
Actually, I love the example of the patient that you shared where you took a watch and wait approach, and you've had such success, and the patient's had 2 babies since then. You know, it's really interesting. So I'm a 16-year survivor myself personally, and as we've done these Zoom calls with multiple physicians, it's interesting. It's almost like in the early years, we had this big elephant gun of HIPEC, but now we're learning so much more about the disease, and it's almost like we can take that more paced approach. And I'll tell you from a patient perspective, right? It is so, it cannot be overstated, the anxiety. I know you understand that. I can see from your demeanor. And my encouragement to all of us here as patients or caregivers is one of the first things we should have, and I say this a lot, and it's for this reason, but we should have a therapist on our team because it helps us make balanced decisions and consider things carefully. But it's really hard to do watch and wait, but to Dr. Wiatrek's point, I think it can give us longer years of good quality life while we're enjoying and exploring and surfing. And I do surf, and it is hard. Definitely hard, very hard. But yeah, I love what you're saying. I really do.
I'm glad. And I do think that it's important. And I think, you know, back to my fruit basket, now I'm all of a sudden hungry for an orange, but you know, if you do have an orange and you can wait, I think it has to be in the appropriate patient, and it may be the best thing for that patient. So although we don't have a consensus on what we need to do, sometimes I feel like our consensus makes us overdo things in other cancer types because we aren't tailoring it to that patient. So as we learn more about pathology and how it behaves, I think picking the right sort of surveillance for that tumor biology and that specific patient is important. And I'm not sure I want somebody to tell me I have to do every 3 months or every 6 months, because it won't be the same for every patient. Yeah. So that's my 2 cents in that. But I do appreciate those comments. Let's see, do I have one more? Yes.
You have 2 more.
I have 2 more. Yes, I see those. Okay. Hello. I am wondering, Dr. if Dr. Wiatrek suggests for surveillance for somebody with goblet cell carcinoma with signet ring features and intermittent grade extensive perineural invasion and suspected invasion, a T4. So signet ring features is a more aggressive feature. Goblet cell carcinoma has recently been changed in how we document it, whether it's high grade, low grade, or signet ring. And signet ring has the possibility of quicker recurrence. And so I would recommend a more frequent surveillance pattern for you, including tumor markers and CT scans. So I wouldn't treat it like a low grade, even if it's intermittent grade with signet ring features. I would suggest more frequent surveillance. And that would be more tailored to you. You want to catch anything that's there early, because you can get good outcomes with goblet cell, although people tend to see it and get a little nervous, which I understand historically, just because it's, you know, we're talking about an appendiceal cancer group that's a rare cancer to begin with, and this is an even more rare cancer within the appendiceal group. And so it's rare on rare, and it's very rare, but I have seen quite a few of them, and you can get good outcomes. You just have to be a little more aggressive at watching and treating. Not watching, doing, right? Making sure you're not missing something. Okay, the next one, comment. It's so difficult being on watch and wait on my 3rd recurrence while each CT scan shows tumors growing, albeit slowly, having symptoms, but trying to keep positive and just living life. And so this is another sort of point back to the one we just made. And I think it's hard. When I have patients having symptoms, it sort of depends on what are those symptoms. If they're having bowel blockages and coming in and out of the hospital, that's not a great quality of life. And although the trade-off may be doing your 3rd surgery, you get something like that's called a fistula, where you have leaking of bowel contents on the outside, and that's a harder thing to deal with. Or you end up with more frequent bowel blockages because your scar gets worse. I think that's a hard decision to make. And some of that I make with the patient depending on how the first 2 surgeries went and what their symptoms really are and how much of their life it is interfering with. I think it's very hard to watch and wait. I am not, you can ask anybody in my OR and my staff. I have great staff who are on the ball, but patience is not something that I excel at. And so I think it would be very, very hard for me to watch and wait. But at the same time, I think it's important to do that. And so I would have to convince myself each time that it's okay, which is probably what you guys are doing. But if it is just a little intermittent pain here or there, you'll likely have the same thing after your next surgery. And that could possibly be treated. And most of your life is a normal quality of life. And you're living life and you're having fun and you're surfing and you're doing what you like. And it's not interfering with that. Then I would say continue that as long as you can get away with it. Because after your third intervention surgically, I think with each intervention, the numbers go up on complication rate, recovery time, and potential sort of long-term effects. And so there is some data, although all the data that we can read and look at are smaller numbers. And so you have to take, unfortunately at this point, everything with a grain of salt and tailor it to the patient. But with each one, your longer term outcomes, meaning blockage and what I talked about earlier, may be worse. And so you do get to a point where your abdomen is not open enough, where I mentioned we can't do laparoscopic after you do a big HIPEC surgery or cytoreduction. Sometimes after multiple, you just can't figure out what's what, and you're worse on the other side of the surgery, meaning you can't open the belly up. And so trying to not get to that point is what our goal is with patients. And so I hope that answers that question.
Well, Dr. Wiatrek, this might actually be the perfect time for us to pause and just remind patients and caregivers that PMP PALS is always here to support you, no matter what phase you're in, whether you've just been diagnosed or whether you're looking at surveillance and perhaps repeat HIPEC. We're here to support you. And so if you have questions, you can always send them to zoom@pmppals.net. We're glad you're enjoying this presentation today. We're very grateful for Dr. Wiatrek's time, but join us here together as a team of pals. If you're going for surgery or if you're going for HIPEC or chemotherapy, really doesn't matter. We're happy to send a bare bottom bear your way. Just send an email to barebottombears@pmppals.net and you'll receive your bear. I still have mine sitting right here next to me. If you have questions throughout the week, if you're looking for other goblet cell patients or patients with your specific diagnosis, we can help try and make those connections. Just send an email to info and Adele actually answers those and we'll help make those connections. If you have questions about terminology or maybe some of the questions you're having today, Arthur Rettig is a pal. He's not just a pediatric surgeon who is retired, but he's a PMP PAL patient. So he's well versed in our disease and he's able to give a little bit of insight and help out along the way. So feel free to email him. Our most popular program is the Get Well Cards program. Each of us who have received Get Well Cards will never forget receiving a box of cards reminding us that we're not alone, even though we're fighting this rare cancer, because they come from patients all around the world, just like we're seeing on this call today. So we support one another and you will love that. And I really encourage you to sign up for that. And finally, if you're here for the first time, send an email to starterkits@pmppals.net. We're happy to send you that starter kit that's got information about appendix cancer. We have chapstick that you may need as you're going through chemotherapy. Antibacterial hand wash is always going to be useful. Notebook for taking notes, some wet wipes, which you're probably going to need as you're recovering from surgery, and a super helpful little set of cards that says, hey, I can't wait. I'd love to jump in line if we're in a long line at the bathroom. So that's what we do throughout the week. We do ask also for your donations. As we are a wholly donation-run organization. This doesn't make money for any of us, and in fact, it costs us all money. And we'd ask humbly for your donations on pmppals.net. And if you go to smile.amazon.com, you can sign up for PMP Pals, being the organization that you support, and we would appreciate that very much. And don't forget matching gift programs with corporations. I know I just matched my gifts with my corporation this year, and that'll help keep things going for the benefit of all of us. So as we go through that and remember those programs and how we support patients, Dr. Wiatrek, I have another question for you too.
Okay.
Can we talk about long-term patients and recurrence, what you've seen there, and what the typical approaches are for re-engaging for our long-term patients?
So, gosh, I've sort of seen it all over the place. I think as we learn more about the specific and as we're able to, as I showed you, all of those abbreviations sort of delineate pathologies and how patients were followed. I think some are coming back with disease that they said, well, they told me it was all gone and now it's here. And so I've seen that happen many years later. And then I've seen patients in follow-up. We feel like if we can get 3 or 4 years between a really extensive high PCI patient, that you're winning that game and trying to extend that out. But I have seen some as far out as 10, 20 years. I've had some that are, 26 years with disease, and you're sort of pushing along and even longer trying to figure out what can we do to make your bowel function, because it does typically get to that point where your bowel is just not functioning if you have more disease in your belly, or we can't operate to intervene on the dysfunctional part. And so I've seen a few of those. And then I've had patients that have had their second surgery or their first surgery, and it just never comes back or never comes back in a meaningful way. And there's one tiny thing that we watch for a really long time. I don't know if that's exactly what you were sort of getting at, but again, it's my fruit basket. There's so much variation in there. And I think the one thing I try to warn patients is I tell them to go and read your website and get support there, because if they go to certain places and look online, they only see the disaster stories, and I don't see that often. They're not all disaster stories. And so I warn patients that just, I think, creates more anxiety, which increases your cortisol, which makes your immune system bad. And then things just sort of, you can't live your life, and you need to do that, because this is a disease where we count it in longer years, and you've got to be able to find a way to get back and have a good quality of life. And that's different for everybody, what's good. Like, I'm never going to go surfing, but I'm happy here with my dogs, which I have to put outside, and cats that I'm sure you all still heard screaming in the background.
Chris?
Yes, Charmaine.
I just wanted to say, this might be a good place for me to say, I was diagnosed 23 years ago, and I was treated here in Austin for many of those early years. And then, like I said, saw Dr. Sugarbaker, and I've been 11 years since my surgery. But I can't believe sometimes when I think it's been 23 years for me, and I'm still here.
Mark noticed I unmuted him too. Mark, so Charmaine is on our board of directors, and I love every week asking Charmaine that question. Remind me again, Charmaine, how many years it's been. So I always appreciate that. Mark McMahon is also a director on our board. Mark, you've got me beat. You did in our competition here. I'm still trying to catch up.
Sort of like birthdays, it never happens, right?
That's right. Yeah. So Mark, tell people how far are you out now?
All right, well, I'm going to tell you a truly happy story, and that is I've got to the point, Chris, where I've actually stopped remembering how many years it's been.
That's good.
So I look over there at my son, who's going to be 21, and I remember he was 3.
Yeah.
So that means that I'm in my 18th year from my surgery.
Awesome.
So that's a pretty amazing feeling. And while Dr. Wiatrek was talking about all the different techniques that she recommended to her patients, I was remembering doing all of them. I actually had a quick question for her, and maybe this just goes to show that when I had my surgery and the years following, that was a long time ago, but I did CT scans and I had a lot of contrast that I had to unfortunately either drink or have injected prior to my scans, or both at some cases. And is this no longer required for patients who are doing CT scans? Because I'm happy to report I haven't had to do one for a while.
So the contrast actually helps us see things better. I don't always give oral contrast because the way we're doing it now, you don't need to. And the oral contrast just makes you have diarrhea, which is, it's not a just thing for people who may have smaller or less intestine. It can be pretty awful. So I don't require that they have oral contrast. I do like the IV contrast. And really for a CT scan, it's an iodine-based contrast. So unless you have an allergy, it goes away. And unless your kidneys are bad, it will all go away and doesn't have any problems. If you have sort of some dysfunction of your kidney, you can every once in a while get a kidney injury from it. It is a little bit more rare to have that, but that's why we check to make sure your kidneys are functioning well right before you get the scan and that the patient is pretty hydrated before they go in. So, you know, the risk for that IV contrast is not long-term. It's just the MRI contrast that's a long-term sort of potential with multiple scans. So, and you know, the stuff that you take orally comes out, you poop that out. So that's gone and it doesn't come back, nor do you want it to. And the IV stuff, it doesn't really leave any long effect. So I think you're good, and I'm glad you're not needing to get scans. What I will say is it's interesting because in my surgical oncology world, I now have a partner here in Austin that does these too, but I was the only one here in Austin doing them. And my clinics are longer now because they're like, well, you have all your HIPEC patients. Those are long-term survivors, you know, and they're treating some of the others that we don't see that as often. And so I have a lot more long-term survivors that I follow. And so I see that in my clinic volume, which I love seeing. I've been here about 6 years. So, and it's not just me noticing, my staff and my other partners are noticing that I have more. So, you know, that's always a good thing. So it's not just one or two here or there. There can be a lot of them.
But just because I'm not doing scans doesn't mean I'm not still following, right? I still do the CEA and the 19.9 once a year, and I have my little Excel spreadsheet, and I plot my numbers. So,
perfect. Yeah, I'm almost getting to that point with one of my patients, but I'll tell you, I extended out to 18 months for the scans. At some point, I'm going to let patients get scanned and not treat myself and actually treat the disease. We worry. We worry about you guys. Yeah.
No.
Yeah, Dr. Wiatrek, you've referred to the acronym PCI, the PCI score several times, and yeah, most of us know what that is. But for the benefit of the group, could you explain what that means and how it's computed?
Yeah, so it's a peritoneal carcinomatosis index, and it's sort of it was designed way back by Sugar Baker, and it splits the abdomen up into quadrants, and you get numbers on how much of that area was covered with disease or that needed to be resected. And so it's a number that goes from low to high, and there's a range in that. I will say most of the studies reference that because it's one of the ways we've used over time to compare patients, and it's one that's been there long enough so we use it quite a bit. There's some problems with it because it's very difficult to do without the surgery, you know, doing it by scan, which I showed you can't really see stuff on the scan, so you can't get an accurate PCI to sort of determine if it's high or low before the operation. And then at the end of the day, they will say the higher PCIs may not have as long a disease-free survival and may not have as long of overall survival. And I think that's just because there's a lot of disease in there and it takes longer to get the disease out. Now, if you can have a high PCI though, and you get something called a complete cytoreduction. So I document I kind of quit calculating the PCIs, but I document in a way that I can go back and calculate it. What I put in my notes that I believe is more important is whether or not you got a complete cytoreduction, meaning was it microscopic disease? Was there a little bit of millimeter disease left, or was it, you know, a couple areas of 2 to 3, and I put where those areas are so we can watch it. But that becomes even more important than how much. And then at the end of the day, the PCI, I think, is helpful in sort of figuring out where you fit in, and it's one more piece of information to add in to tailoring your surveillance. But the PCIs are nearly always higher for the low-grade patients, and you know, they're overall, the low-grade ones, if you can get a good cytoreduction, do quite well, as we've seen. So did that answer that?
Chris?
absolutely, thanks.
Paula?
Chris, I have a, oh, go ahead.
No, Paula, I was just
Mark,
saying,
were
go
you-
ahead.
Yeah.
Yeah.
Oh, okay. I'd like a comment from the doctor on my situation. I do have signet ring cell, and I got my CRS HIPEC at the end of January 2017. At that time, my surgeon said, this will probably last you around 3 years. Well, it's over 3.5 years now. And I visited him recently out of town. And I said, doctor, I'm by nature more proactive than reactive. And it's getting pretty long. You said I would probably be getting some issues 3 years plus in, which I am. I have not had any blockages thus far or whatever. But what my medical oncologist did here at home, and he is mostly a colon cancer oncologist, not appendix. He put me on 5-FU infusion in May of 2017, and I've been getting only 5-FU since May of 2017 till now, every 2 weeks. And he's never mentioned giving me Avastin or anything like that. He did beforehand. In the pre-surgery, I had about 8 treatments of Folfox and Avastin. But since that time, he only has me on 5-FU. I have not any symptoms. So my surgeon says, I said, it's getting pretty long, and you can't really see these things by imaging or maybe by CEA either. And he says, well, I really don't want to. You haven't had any symptoms. Your labs are good. And at this point, I don't want to do anything. That's making me nervous because it's getting along. It's getting along. He calls me a unicorn. I don't know if that's a medical term or what that is, that I've gone longer than many of his patients without a problem. And I don't know what I want him to say. I don't know if I want him to say, oh yes, we're going to do another one of those gosh awful horrible surgeries or not. But I do want to catch it before it goes too long. And I didn't know what your thoughts are on being that long, being on 5-FU only, or if you have any comments about that.
When I see patients, I like to look at their full pathology. I like to know what their cytoreduction completion is, because the signet rings do get chemo, so I think that's appropriate. I will tell you, it depends on what I find postoperatively as to whether or not we recommend maintenance. So what you're on is really a maintenance chemotherapy.
It is.
And I've had patients on maintenance for a long time, and then eventually they decide, hey, I'm done with this. I want to just take a break. I've had patients on maintenance Avastin for a long time with a very high PCI, and it never came back. And now they're off both. I've had patients on 5-FU plus Avastin now that the new data has come out showing that it may have an impact on peritoneal disease. But I think a couple things for you. If I was looking at it, I would want to see your full path, number one, and look at your off note. But if a patient had a complete cytoreduction, even if they had signet rings, and I will tell you, I sit down with my pathologist because a couple signet rings may be different than every cell having signet rings. And if you had the mucinous component, then although when we say you're a unicorn, it means that you shouldn't exist, but you do. It may be that you had more of a mucinous variant that responded to the cytoreduction quite well, and maybe just a few of those cells that were more aggressive, and we've treated them. And so when I say 3 years, that sort of depends on the tumor biology, and that's sort of the average time, and that's our goal. We want to get to 3 years, but I've definitely had patients go longer before needing anything else. And I think at some point, that's a lot of chemo for a person to have.
Dr. Wiatrek, what do you think the role of Xeloda could be here?
Xeloda is a little different, and it depends. 5-FU, infusional 5-FU tends to be tolerated quite well and a little bit better. The pills can cause some massive diarrhea, and in a patient who may be missing some bowel, sometimes it's not tolerated. And there's some patients that can do it, and I think it's fine. And I have really good medical oncologists that we have these discussions on. So what we're talking about right now is what we talk about at every tumor board we have. What are we going to do for this patient now that they've had surgery? And I think if you have no evidence of disease, it would depend on your initial biology, whether or not you had an initial elevation in your CEA, CA 125 or CA or CA19-9. If you have those elevations, the CA19-9 patients that are elevated may do worse and need more systemic therapy. But if you never had an elevation, you don't really have a way to follow, I would discuss it with your medical oncologist about whether or not you just need a break. I mean, I would never recommend a preemptive surgery for a patient. I would have to see something. I would have to have a symptom, meaning you're blocked, or you start to have blocking symptoms. You've had an elevated, say your CEA was elevated to begin with, or a brand new elevation in a tumor marker. I would get scans to look for disease, or if on your scan there is evidence of disease, meaning I see something that makes me know, like maybe we've been following you this whole time and there are little things that are disease. Typically they will grow and I biopsy them to prove them that they're there and that it hasn't changed morphology or it's not behaving differently. And so I will tell you, there is absolutely no data to say what to do for patients. And so there is no consensus, and we debate this and go back and forth, and we do tailor that more to the patient. You know, I think it's always okay to go back and look through everything that you've had and revisit whether or not you're really benefiting from it, and if something different needs to be done. And although patients don't typically just go on Avastin, I've had some patients on single therapy. Just because we're too nervous, it's going to come back. And so, like I mentioned before, sometimes we feel like we're treating ourselves because we're nervous for you guys and feel like you're informed. But I don't think it would hurt to have your pathology looked at again and review all your scans and look at your numbers and see where you're at now. It's a lot of chemotherapy. That's a lot of years of chemo.
It is. It doesn't bother me. I tolerate it very well. I come home with the pump and, you know, for the 46 hours or whatever, it just really doesn't bother me. And maybe that's why they're continuing it. And yes, my CEA was elevated initially before surgery, and it is not all now. So I guess that's what he's doing. It's just, you know, when he says, oh, if you start to get symptoms, come see me. Well, I'm in St. Louis, he's in Pittsburgh. So.
Oh, yeah. Yeah, you know, it's interesting because with I find in my patients, this is all, of course, you know, as a surgeon, antidotes are not something you're supposed to change your practice on, but I feel like sometimes that's the only data we have for you guys. But I find in my patients that the CEA helps me decide what needs to be done. So if you needed a chemo break for whatever reason, if you don't, you can discuss it with your medical oncologist or to decide if you need a break or want a break, or maybe when COVID's over, you want to travel, or you're like, I want to take off of this for a while, and do a test and see if it makes your CEA go up, because I find that's really sensitive in patients who are elevated to begin with.
Okay. And I was thinking about perhaps seeking out a surgeon who would be at this present time more aggressive and would do it. I don't know.
I don't, you know, I love it because as you guys get farther, when I first see you guys the first day, a couple days after surgery, you're like, what did I do? Why am I here? This hurts. And as you get farther away, I think you tend to forget how much of an investment it is.
It is. It's a huge investment, as many of us sitting here know.
It really is.
Not
but
something you want to do.
Yeah, but as you get farther from it, you sort of start thinking, hey, it wasn't that bad. I don't remember it. You know, and do I need I would say I would not volunteer for an additional surgery if we don't have some evidence that you need it, because no matter what, you're going to have some scar. Even if the chemo made you one of those people who don't have as much, there will be scar in there. And, you know, the risk of that surgical component, meaning you get a fistula or you scar in a way that causes blockage. So you could come out worse on the other side, and you don't want that without the benefit.
Right. Some doctors here in town have said, no, you don't want to do that. So I don't know, but thank you for your input. I appreciate it very much.
Of course.
Well, and I will say that part of what PMP Pals does, we want patients to be educated, because we find educated patients are able to make better decisions. There is a broad spectrum of opinions out there, from our local surgeons to what our specialists might tell us. And we really encourage you to talk to the specialist for sure. If you're interested in consulting with Dr. Wiatrek, we'd be happy to help facilitate that. We're getting great advice here today. I really love what we're hearing. And so we're happy to do that. And we're blessed to have been attending the specialists presentations and their get-togethers every year. So we know almost all the specialists. We're happy to facilitate any introductions that you'd like. So just
Yeah,
reach out to
and
info.
if I could
help that.
jump in, we didn't get a chance to clearly explain where Dr. Wiatrek is from. So Dr. Wiatrek is at Texas Oncology in Austin. And as you can tell, she is very, very experienced in the treatment of this disease. And not only is she highly skilled and experienced, but I think you can see the care and compassion that she brings to each and every case. And so we appreciate our relationship with you, Dr. Wiatrek.
Thank you.
Thank you.
I feel like, you know, you can't choose this sort of disease process as an aside. You have to have a passion for it because the cases are long. And, you know, I think there are certain of us surgeons who don't care if it's long. And my OCD, I'm going to stay there until I get it right. And that is important for you guys. And so what I've found is this actually is a great fit for me, and I have a passion for it. And so you do want that, because if they're not wanting or don't seem interested in it, then that's not the person you want sort of making decisions for you. And I can tell you, not all of us like this. And in the same line of things, there are certain oncologic and surgical stuff that I also don't like. And luckily, I have fantastic partners who are happy to take care of my patients the way I would, and I'm happy to take care of their patients the way they would. So we have a great team where it's not just, although I'm the only one that does it, I'm not the only surgical oncologist in town managing my patients, and so it's a great setup. And I do love doing it, and we have built a great program here. And I think that it's some of it is that I can control pretty much everything from beginning to end. And although I fear sounding like a control freak, the lack of having, you know, I used to do this in a setting where there are a whole lot of different hands on the patient and the outcomes were different. And now that I can control most of that, my outcomes I can see a difference. So I love this setup, and I will continue to do it. So I will be here in Austin if anybody needs me.
Let me, you know, one of the things that I have on my mind, let me just explain. When I finished my surgery out of town 11 years ago, I needed to find a local oncologist to monitor me. I was changing from another doctor. But anyway, I asked Dr. Declan Fleming, I know you know him, if he would follow me, because he helped me with some aspects. No, I'm a surgeon. You need to find a medical oncologist. And Dr. Chada was the person in Austin at that time 11 years ago who had probably the most concentration of patients with appendix cancer. And now, you know, we have you here too, thank goodness. But do you follow patients who have had their surgery other places? It sounds like you would like to have those patients from start to, you know, through all of the surveillance and everything. Do you see patients who had surgery at MD Anderson and want to have more local surveillance and help, or how do you approach that?
You know, it's interesting because we are not that far from MD Anderson, and I actually like my program and my setup. I will tell you as a surgeon, and this is why I will always make the argument that if you can get specialized care closer to home, you should do that, because as the surgeon who takes care of these patients, like I have patients from other states, and I require them to stay around and follow them. And then I follow them with telemedicine afterwards, and I keep following them. And so if you're having surgery somewhere else, that surgeon needs to manage you. There's nobody that's going to know you better than your surgeon. And so I know exactly what's in the belly. I've documented it. I watch my patients. When you've done the surgery, you know what could possibly be wrong, long-term, short-term, where to watch for recurrences, where to check on the CT scan. I always look at my CT scan after I've had and done the surgery, so I know the areas that I'm most concerned about. And so it is not the same care if I haven't done the surgery. Although I'm always happy to see a patient and help take care of them. I strongly tell the patients that if they're choosing to do it in another city, they have to make sure that that follow-up plan with that surgeon is one that they can manage, because it won't be the same care. I mean, I can do it, but it won't be the same as me having done the surgery. If that makes sense.
Mention that when I had my surgery with Dr. Sugarbaker, that wasn't really even something that, I mean, he said if I had an unusual CT scan or something, he would help look at it, etc. But for routine monitoring, he wanted me to establish a relationship here. And And now it would be kind of irrelevant about whether he wanted to do it or not. He's retiring, as we have recently. So there are things like that that will come up. You know, a patient does move or something. So I just wanted to see what your thoughts were. I think you stated your preference, but know that you wouldn't turn me away if I showed up at your doorway.
I am always happy to monitor a patient, and I've actually been the surgeon doing. I will tell you more often than not, I'm usually in the patient after somebody's been there, and it's not always a HIPEC. So I have done the second HIPEC on multiple patients, not having done the first one. So it's not, but I will monitor that patient after I've done their surgery, and I require them, even if they're out of state, to at intervals see me, at least by telemedicine now that we can do it, and or come in and get the scans where I can review them, because it's just not the same level of care. So I have done that. And now most of what I do as a second surgery is after the diagnostic surgery, meaning they've done the appendectomy or they've done a right hemicolectomy, and now I'm going to do the peritoneal disease. And so most of the time other surgeons have been in there, so it's not that you can't operate on somebody that's already had another surgeon, and I'm happy to see that person in consult or secondarily. But if it's right after your surgery and surveillance, I think those little nuances are just not the same unless you've been in the OR with that patient. So, you know, my partners who take care of my patients immediately post-op on the weekends, like for instance, I have one in the hospital now, my partners are seeing my HIPEC patient, but they also know how to reach me. If something is awry, they're gonna call me. And I know that patient better than anybody, and it's the same way as if that patient. So it's variable whether or not you can reach that person and if the care is the same. So yeah, I hope that I'm happy to see patients. I don't necessarily, when they go and they have their surgery and they come back and there's a lot of problems, and I can usually, you know, I like to fix my own problems if it does arise, because I know how to do that the best for that patient, and the outcomes are better.
As we're approaching an hour and a half, Dr. Wiatrek, there's one more question I want to ask, because I don't think we covered this particular one today. And if we did, I apologize if I missed it. But the question is, can low-grade PMP pathology change to high-grade after a couple recurrences?
You know, it's interesting. There has been documentation of transformation from low-grade to high-grade. You know, it makes me sometimes wonder if it was not as an experienced pathologist, or they didn't look at everything. When I do my pseudomyxoma patients or my cytoreductive patients, I send 20, 30 specimens because I want them to separate it out and look at everything. So I think it depends on how robust that pathological review is. So it might be that it was all along, maybe some areas of higher grade and it was missed, or it was transformed, and I don't think we've completely figured that out. So I have read about transformation, and what I can tell you is I have seen patients, tumors start to behave more aggressively, but under the microscope, they look the same. And so it's frustrating for us because we don't yet know why they're behaving more aggressively or growing into things, whereas before they just sort of sat on things. And so we're not seeing high-grade cells, but we're seeing poorly behaving cells. And I think there's still some stuff for us to learn from a pathological standpoint. So it may change its biology and behave differently, but may look more similarly under the microscope. So I think there is that possibility. I'd like to, I think anything is possible, actually, with this disease.
Interesting. Thank you. Are there any more questions that people would like? And I'm going to do my best to page through and look for
Kelly has a question.
There we go.
Hi, and this has been very informative. Thank you so much. I actually have two questions, but I'll start with the most important one in case I know we're running short on time. Blood tumor markers, the CEA and the CA125. I had my initial CRS HIPEC in February of 2019. It was thought to be CC0, but I'm looking at a recurrence right now. When I'm looking back at my Excel spreadsheet of my blood tumor markers, I noticed that my CEA last year did not get elevated till my third round or fourth round of FOLFOX after I had systemic chemo after my surgery. And then it came down after chemo was stopped. Currently, I just finished 3 rounds of FOLFIRI in anticipation of having another CRS HIPEC. And my CEA was normal when I got my July CT scan that had abnormal results or suspicious findings, but it didn't start getting elevated until my second round of chemo. Does the CEA, can it be elevated because of chemo?
You know, this is interesting because I sometimes see that, and the medical oncologist will call me. They're like, the CEA is going crazy on us, and then it goes back down. I don't think we know exactly why some patients do that. Our theory, and although unproven, is that maybe some of the cells are lysine and it may give off different antigens that way. CEA is not very specific. So there are other things that can make it elevate. And so it sometimes wonder, you know, it makes me wonder if it's possible that the way that chemotherapy affects your body sort of does something different to overall, because you can get CEAs from other problems.
Okay.
That's hard because it's happened to you both times you've been on chemo. It's gone up, and I have seen that. Now, I will say sometimes what happens is patients are getting their labs drawn at a different office, and then all of a sudden they're starting chemo and they start getting the labs drawn at the oncologist office. And sometimes those the ranges are different at those offices, so it may look like it jumped, but it's a different sort of range. But if it's all been at the same lab, that's hard to sort of interpret, I will say.
Okay, and related to that, the CA-125 started being elevated with my abnormal CT results. The blood was drawn the same day as the July scans. And that has continued to go up, and it just started coming back down, but it's still elevated over the normal. But I only did 3 of the anticipated 4 rounds of FOLFIRI. So my question is on the CA-125, how good of an indicator is that the chemo was working or not?
CA-125 tends to be more elevated in peritoneal disease. So, you know, we use that. It's notorious for an ovarian cancer marker. I'm sorry?
Oh, well, I first had a hysterectomy thinking I had issues.
Yeah, I mean, it's elevated in surface malignancies, and ovarian is the most common surface spreader. And so we follow that for ovarian cancer, and it's pretty sensitive if it's elevated to begin with. What I do see is patients who have a higher burden of peritoneal disease likely have a CA-125, including men who I have to argue with insurance to get approved because they like to remind me that it's a guy and not a girl. I'm like, there's not all cancer is ovarian. But I think it's more sensitive, or you could say based on data, it's probably more sensitive for peritoneal disease. Whether or not it going up and down is helpful, I think that seems to be maybe more reliable for you than CEA, although a lot of us believe CEA should be the most indicative for a GI primary. One that I always get to sort of level it out or maybe be a tiebreaker is a CA-19-9, and not everybody thinks to check that, but that one has been shown if it's high, you may have a more aggressive biology, which may mean, you know, so the aggressive biology tumors tend to respond to chemo better. So I think you can see changes in that one more substantially. Okay. And I mean, I've had patients, even with my cytoreduction and a very high CEA, it takes a while for it to go down after my surgery, and it sometimes never goes to normal for whatever reason. And it's one of the reasons why we don't just use tumor markers to make our decision, because there's so much else that goes into it, including the scans and symptoms and what the biology is. So it's just one piece of it. But if they haven't gotten the 19-9, you may want to see what that is.
Oh, that's been normal throughout everything.
Yeah, I find if it's normal, it likely stays normal and never will change. And so I kind of quit checking it.
Okay, thank you.
On the flip side, what about patients who never have tumor markers that are elevated? besides obviously doing a CT and an MRI, which sometimes doesn't show until it's a certain size, what do you do for those patients that never have an elevation in markers?
There are some patients that will never have one and have never had one. I feel like sort of you win the lottery in a good way or a bad way if they're elevated, because you have something that's pretty sensitive to follow. But if it's not elevated, I'm not sure you're hoping for it to be elevated. Typically, if they're not elevated, it just means your tumor doesn't give off those antigens or doesn't put that into your systemic system to check. I will tell you that I tend to not follow those unless I'm it doesn't completely, it doesn't always make sense when I say it out loud, but if I'm deciding not to do scans because we've had 10 scans that are normal and that was the only thing that was ever different on the patient, then sometimes I will check their labs, just because if it does all of a sudden change, then you definitely want to scan, because would not be normal for that patient. So if it was never elevated, then all of a sudden that is something you would want to investigate. So I think you have to decide how often you want to do that in a patient who's never had an elevation, because it doesn't mean if you had a recurrence that it wouldn't be elevated in the future. As we talked about earlier, those biologies can change, and how the tumor behaves may change. So it could change how it gives off the tumor markers and what you see in blood. So, that's something that you have to tailor towards the patient in the pathology. And I have some low-grade patients that were never elevated that I check maybe every couple of years, or if they start having symptoms, I will send it.
The other question I had, if one minute, you mentioned that the tumor sizes or I guess the tumors are not seen until they're a certain size on these scans. Well, I think you said 0.2. What is the length of time where it takes to grow to that size in your view?
So the length of time depends. I feel a little bit like a broken record. Y'all probably tired of hearing me say tumor biology, but we say that all the time because every tumor biology behaves differently. So if you're a low-grade tumor that don't have many epithelial cells, so when you have to have cells that make mucin, and they make them at different rates, is what I've noticed. And so it's completely variable to the biology on how long it takes to get to a size that you need to treat. And so mucin in and of itself is inert. So acellular mucin doesn't have a cell that can grow, and the mucin doesn't divide like something on science fiction. You have to actually have a cell that makes the mucin that's there, that then divides and grows and makes more mucin for it to be able to see. So when we're looking at a mucinous tumor, those tumors start to grow, and it needs a certain amount of cells to actually show something. And you can see stuff to be about 8 millimeters to a centimeter. If it's the type that just sort of spreads along the surface and makes the surfaces all look a little thicker instead of pooling in one place, then it never gets to the point where you can see it. And so I have seen some of those and followed some patients that have some surface disease along the liver for a long time until their tumor markers start to finally go up, or it is a definitive increase in the size on scans, because sizes on the scan, when we cut through on a CT scanner, it's 2 millimeters at a time. So if you measure a millimeter difference, I don't think that's accurate enough for me to say it's grown or gotten smaller. It has to be more than 3 millimeters to 5 millimeters for me to say there's been a change. And so that length of time to make that change is different. And when it's slow growing, we love it because we can give you a longer sort of time away from treatment or needing your second surgery. I don't know if that answered your question. I think you got a more complicated answer than you asked.
That works for me. Thank you.
Okay.
Well, as we wrap up for the week, I first want to say, Dr. Wiatrek, this has been a special Hope Zoom call. I really appreciate your thoughts, and it's clear that you have a personal approach to treating this disease, and so it's really greatly appreciated. Thank you for taking the time for being here.
My pleasure. I've enjoyed it. Good luck to all of you guys.
Thank you. As we do wrap up, there's a couple more things I'm going to point out. Dr. Wiatrek had referred to our past Hope Zoom calls, and Dr. Wiatrek, I'll even say, if you didn't get to look at the particular presentation from Dr. Joseph Mizrahi on pathology. It was really, really good. Even physicians will appreciate it too. You'll see we have quite a few presentations here, but Dr. Joseph Mizrahi's was a particularly good one. You can find those on pmppals.net under the Get Information Then Hope Zoom. And we'll just remind folks again how they can keep in touch with us throughout the week on the internet at pmppals.net. There's tons of information, past videos, and ways to get support there. You can register for the Future Hope Zoom calls on our Facebook page. And as we've shown the past Hope Zoom calls and had Dr. Wiatrek here today, on October 24th, we'll have another physician presentation with Dr. Vadim Gushin from Mercy Medical in Baltimore. He's a partner of Dr. Armando Sardi, and so we're excited to have him in just a few weeks. So if you've enjoyed this, we hope to see you then. And with that, we'll call it a wrap. And again, Dr. Wiatrek, thanks you so much for taking the time on a Saturday. We really appreciate it.
Of course.
Yes,
It was my
absolutely.
pleasure.
Thanks, Steph.
You're welcome. I enjoyed it.
Great. Well, everyone have a great week, and we hope to see you next weekend. Take care.
Thanks, Chris.
Bye,
Bye.
everybody.
Thank you. Bye.